Phencyclidine was first used on humans in a medical setting in 1957 in hopes that it could replace barbiturates as a painkiller in surgeries, but it was quickly discontinued by the early 60s due to the negative effects that it was having on patients. However, by 1967, it re-emerged in San Francisco, this time as a street drug named the Peace Pill, or PCP, as I will be calling it through the rest of the video. So, what is PCP? PCP is a synthetic hallucinogen produced in illegal labs that produces cognitive and behavioral changes. It has over 50 street nicknames, including Angel Dust, Whack, and Rocket Fuel. Inhalation accounts for over 70% of PCP's use. A popular way to inhale it is to take the liquid form of it and to dip a cigarette or joint in it to create a dipper. IV is the least popular route of administration. It's very quick for the effects to occur, but it doesn't last long. As far as the absorption sites, this depends on the route of administration. For example, if you snort it, it will get absorbed by the mucous membrane, or if you inhale it, it will get absorbed by the lungs. Pills are also a popular route of administration. However, they have to go through first pass metabolism, so there will be reduced bioavailability if you take the pills. PCP is also metabolized by the liver. PCP acts on the autonomic and the central nervous system in order to create many of its symptoms, including feelings of being detached from oneself and your environment, involuntary movements such as involuntary eye movements, numbness, a loss of coordination, as well as perceptual changes such as visual and auditory hallucinations. The perceptual changes are the symptoms in which I am most interested in for this project. It is interesting to see in how old literature these perceptual changes would have been diagnosed as acute schizophrenia. This is no longer the case, however. As far as half-life goes, this is very dependent on the user. PCP likes to depot bind, especially to fatty tissues in the body. So in naive users, the half-life can be at a minimum of 7 hours, but in more chronic users, the half-life can be up to 3 days. PCP is a non-competitive antagonist, and it binds to NMDA receptors on GABAergic cells. GABA inhibits pyramidal cells so they won't fire. However, PCP blocks these GABAergic cells, so the inhibitory GABA can't inhibit the cells making glutamate. So essentially, these brakes are lifted and the pyramidal cells become overactive and can release an abundance of glutamate. Glutamate is very excitatory, and without the GABA to inhibit it, there's an overexcitation in the brain, in areas such as the anterior cingulate cortex. This is the area where the literature shows that the more glutamate there is, the more likely we are to see these auditory and visual hallucinations. Other areas that contribute to this are the thalamus and other parts of the prefrontal cortex. Other areas in the brain affected, such as the basal ganglia, contribute to other aspects of the PCP effects, such as movement. As stated earlier, PCP is metabolized in the liver. With chronic use, we can see metabolic tolerance as the metabolites in the liver have to increase to make up for the PCP usage. We also see withdrawal symptoms such as depression. This might be explained by the fact that GABA has to make up for PCP use and release more. When PCP is not being used, GABA is inhibiting the excitatory glutamate a lot more than it did prior to the first PCP use. There is good reason to believe PCP has a high addiction and abuse potential, especially with how you use it. Inhalation is fast, having an onset of only 2 to 5 minutes, and the symptoms stay over 40 minutes, according to the DEA. We know this increases addiction and abuse, as drugs with a quicker but long onset have a higher abuse likelihood. Pills are going to be less addictive as they are slow and have a lower bioavailability because of first pass metabolism. They have an onset of 30 to 60 minutes. Furthermore, we know that there is metabolic tolerance and physical dependency. We also know that withdrawal symptoms can be a reinforcing factor to PCP use, as one might use it to avoid these negative, uncomfortable symptoms, such as depression. There is also psychological dependency that comes with chronic PCP use, as illustrated by the graph. The graph shows dopamine and how it's reinforcing. I will note that the graph is showing specifically ketamine and not PCP, but I got it from the textbook and it talked about PCP and ketamine having this same dopaminergic mechanism. The graph shows that dopamine is very reinforcing when it comes to PCP, not necessarily saying that dopamine likes the drug, but it makes somebody want it, leading to the psychological dependency and cravings for the PCP.